So, tēnā koutou katoa. Welcome to tonight's webinar with the lovely Natalie Cowley. Natalie will be sharing her expertise on acute assessment of paediatrics. She's been a long-standing registered nurse at Starship Hospital for the last 13 years of her career while growing her knowledge and expertise. 10 of these glorious years have been in the Children's Emergency Department, and the last 3 have seen her add the nurse educator role to her hat. She comes complete with a postgrad diploma in advanced nursing with a focus on child health and education. And at this point, I'll pass you over to Natalie. Thank you.
Hello, everybody, and welcome. So I'm going to try and get through as much of paediatric emergencies, paediatric differences in anatomy and physiology, and some common emergency presentations. There's a lot to cover, so I will try and cover as best I can, and I'll talk quickly so we get through it all. Obviously, if you have any questions, jot them down and we'll get to them at the end. Okay, so we're going to cover some paediatric differences. We're going to cover the structured approach to assessment for paediatrics, some common emergency presentations, a couple of other paediatric essentials, and then if we get time, we'll go over some other common paediatric presentations and then some tips and tricks in dealing with peds. So first thing to remember is that paediatrics have quite a varied range in their normal vitals. So heart rates for an under 1 can vary from about 110 to 160. So 160 can be a normal resting heart rate for a neonate, whereas obviously as you get more into adult range, you're looking at sort of 60 to 100. Some really fit sort of 10 to 12-year-olds will sit under 60. But if you have a neonate or even a 1 to 2-year-old with a heart rate of 60, you need to be really concerned. So it's quite important to know your vitals and know the differences so that you can pick up when children begin to decompensate. So in terms of differences in the airway, they have a relatively large and floppy tongue. It gets in the way a lot, so you need to be careful in terms of tubing. They're obligate nasal breathers until they're about 6 months old. So when they get snotty, the first thing to block is their nose, and then they will try and breathe through their mouth. When they're feeding, they can't do that anymore, so often their feeding will drop off. They've got quite a small airway diameter, and it makes foreign body occlusion more likely. And also when they've got edema when they're unwell, about a 1 millimetre level of edema can have quite a great effect on the airway. Their larynx is higher, so it sits at about C4 as opposed to C6 in adults. It's more anterior, and it's also quite cartilaginous. So this means that they're quite at an increased risk of aspiration, and they're also at an increased risk of compression of the airway if they hyperextend or flex. So that's really important to remember when you are positioning them in terms of opening the airway. They've got quite a short neck and a trachea, so it makes the foreign body displacement into the right main bronchus quite common, and also means you are quite likely to tube into the right main bronchus, and it makes extubation quite common as well. Their cricoid ring is also the narrowest part of the airway. So this is until about age 5, and then it becomes like the adults at the glottis opening becomes their narrowest part. They've got quite a large occiput, so this means when they're lying on their back, their head will naturally tilt forward, which will start to occlude the airway. They've got quite a small face and mandible, so obviously they need smaller masks when you're bagging them. The floor of their mouth is quite easily compressed, so when you're doing a bag valve mask, or even when you're adjusting the airway, you need to be really careful that your fingers aren't compressing the bottom of their mouth. They're obviously at risk of loose teeth and orthodontic appliances depending on their age, and they've also got quite large adenoids and tonsils, so they can get occluded airways really quickly when they're unwell in terms of that, because they're already quite big anyway. So when we're assessing the airway, we're going to take quite a structured approach. Like I spoke to before, positioning of the airway. So with little babies, we call sort of the sniffing technique. So you kind of just adjust them so they're neutral, as if they're just taking a wee sniff, as opposed to the kind of hyperextend that you do with adults. Sometimes to do this, because of their large occiput, what you can do is get like a folded towel or a blanket and just pop it behind their shoulder. So when they're lying, they naturally, you change that angle between their head and their shoulders. You want to obviously be looking at their breathing. Are they crying or talking? Are they making any noise? Are they snoring or gurgling? That's not normal in kids. They shouldn't snore. Do they have any increased secretions, and can you see any foreign matters present? And so now we will move on to breathing. So they've got less effective compensatory mechanisms. So they'll compensate for a short time, and they'll use their accessory muscles, and they'll increase their respiratory rate. But then because they've got fewer type 1 slow twitch fibers, they will eventually tire, and then they'll just fall off their perch. So they'll compensate for a while, but then once they've reached the end, then that's it, they're over the edge. They're naturally diaphragmatic breathers when they're little. It's quite flat. So it means that if there's any pressure from above or below, it will affect its function. So sometimes that's why it helps them sitting up. Even the smaller babies, it helps them to be upright to help with their breathing. They've got a higher metabolic rate and demand. So the oxygen consumption in a neonate is twice that of an adult. This is supported by an increased rest rate. So it's part of the reason they breathe a lot quicker. They've got quite a compliant chest wall, and their ribs lie quite horizontal. So this means that in terms of trauma, it's really common to get pulmonary damage without rib fractures. So just because they don't have a rib fracture doesn't mean they don't have a pulmonary injury. It's really important to double check all of that. They've also, because of their cartilaginous sternum, they can't actually increase their tidal volume with their muscles. So they tend to just increase their rate to help with their demand. They've got quite a thin chest wall. Again, this is really important in terms of trauma. And they've got fewer and smaller alveoli. So they've got less surface area for gaseous exchange. And it's why giving them a little bit of peak can be quite effective. So when you're doing a structured approach, you want to be looking at the effort of breathing. And I'll go further into that in a couple of slides. But also the efficacy of their breathing and the effects that their breathing has on other systems. In terms of the effort of breathing, you want to be looking at their rest rate at rest. So you need to know your values and be able to look and see how quickly they're having to breathe, whether it's normal for their age or not. You want to look at their recessions and how severe they are, whether they're mild, moderate, or severe. You're listening for inspiratory or expiratory noises. This could indicate some kind of obstruction, whether it be a foreign body or whether it be like a croup or other kind of swelling, infection around the airway. Are they grunting? Really sick babies will start to grunt. So they're kind of attempting to create their own positive end pressure. So they're trying to keep those alveoli a little bit inflated when they breathe out, so that when they take their next breath, it's a lot easier for them. They'll use their accessory muscles. They'll also start to head bob. They will flare their nostrils. This is also quite a sign of severe increased work of breathing, because they're at a last-ditch attempt. They're trying to increase the diameter of the airway. They'll also tug at their trachea. Again, that can go from mild to severe. When they're really unwell and they're like impending respiratory arrest, they'll start to gasp. So they'll stop crying and they'll just be gasping. So these are just some signs of effort of breathing. So the first one on the left is showing some subcostal recession, so underneath the bottom of the ribs. The middle one is some substernal recession, and then the third one is your intercostal recession, so where they're breathing in between their ribs. So a normal baby breathing normally won't have any of these signs of accessory muscle use. As they get more unwell and they're having to work harder to breathe, they'll start to show these signs. It's really important to remember that increased respiratory effort is absent in complete exhaustion. So once they've reached their peak of working, they'll just get so tired that their respiratory drive cuts off and they no longer are working hard at all. Also, central respiratory depression. This is usually because of secondary to a toxin or an overdose. So it's quite important to get a really good history, whether it's opiates or recreational drugs. Again, that can depend on their age. Obviously, adolescents are more likely to experiment with drugs, whereas smaller children, toddlers, can find different drugs around the house and they'll ingest them and without realising. And so it's really important to get to the bottom of what they could have ingested. And also neuromuscular disease is a really difficult one. It's really hard to assess respiratory failure in neuromuscular disease, things such as spinal muscular atrophy. So it's really important to use your OBS equipment, because they won't be able to actually show you that they're working hard to breathe. So you need to be looking for signs of oxygen levels and your CO2 as well. This little chap here is showing signs of complete exhaustion. So efficacy of breathing, the chest expansion, you want to be looking at how deep they are breathing. Are they having long or slow breaths, or are they doing quite short and shallow ones? Auscultate, have a listen for ear entry. You want to be listening bilaterally. Is it decreased? Is it normal? Is it equal or unequal? You need to have a really good listen. Often with kids, it's a lot easier to listen on their back as well, especially if they're cuddled against mum or dad. You can sort of sneak in and have a little listen to the back. Infants will use their tummy because they've got an underdeveloped diaphragm and they breathe. Their diaphragm's their main drive in terms of their respiratory. They'll often start to use their tummy, and they do a little bit of seesaw, so their tummy will go up and their chest will go down and back and forth and back and forth. And then obviously your oximetry as well is also really vital. So when they're not breathing properly, they start to affect the other systems. So their heart rate will initially increase, so they'll get tachycardic to try and meet their oxygen demand. And then eventually they'll start to go bradycardic. It's quite a late terminal sign, so you need to be keeping quite a close eye on their heart rate. And if it's starting to drop, is that in relation to them getting better, or are you now worried that they're decompensating? Their skin colour, they can often be quite pale. This can be secondary to a decreased circulating oxygen. They also get quite mottled and they can get quite cyanosed, especially peripherally. Sort of central cyanosis is a worrying sign. Their mental status, babies will be very irritable, very hard to settle, can be quite inconsolable. Older kids, again, can be quite grumpy, but they're also quite sleepy. They're just not getting enough, they're just not meeting their demands. So cyanosis is quite a pre-terminal sign. SATs of 85% in air is quite worrying. You need to be treating them pretty quickly. Circulation, infants total. So infants have about 90 mils per kilo. A child has about 80 mils per kilo, whereas an adult has about 70 mils per kilo. But so small losses can be quite catastrophic for kids. Their heart rate varies with age, so as we were speaking about before, it makes it really difficult to detect decompensation if you're not aware of the variations in their heart rates, depending on their age. Their myocardium is less compliant, so they're not actually able to increase their stroke volume. They can't make their heart work harder to get more blood around their body, so they increase their rate instead. And hypotension, so blood pressures are important with kids, but often hypotension is quite a late sign. They can lose up to 25% of their circulatory volume before they will show signs of hypotension. They've got quite a relatively high cardiac output, and this is required to meet the metabolic demand, but it makes it quite hard for them to keep up with it once they're tired, so they'll have a rapid deterioration once all their compensatory mechanisms have been exhausted. They do have strong compensatory mechanisms, which seems a little bit counterintuitive, but they will do it, they'll use everything they can, but then once they reach exhaustion, they fall off their perch a lot quicker than what an adult will. So what they do is they shunt blood to their vital organs and away from their periphery. So you'll often find that kids, even kids with just a fever, will be quite cool and mottled peripherally. As long as they're warm centrally and that's sort of in fitting with their fever, then you don't need to worry about that too much. But obviously if it doesn't fit the whole picture and they're not febrile and they're otherwise just starting to get quite mottled peripherally, then you need to be a little bit concerned. When you're doing a structured approach, you want to be looking at your heart rate, your pulse volume. So is your heart rate in keeping with the child's age? Is it too fast or is it too slow? Their pulse volume, is it bounding or is it weak and thready? Their capillary refill, you want to be doing centrally and peripherally. Peripherally, obviously won't work if they're using their compensatory mechanisms and they're shunting their blood. So you want to do centrally, and the next slide will show you how we do that. Their skin colour and warmth. So are they mottled, or do they look nice and warm and pink? And their blood pressure. So even though we don't do blood pressures all the time on kids, it's really good to have a baseline, and depending on what they're presenting with, it is really important to get blood pressures. You want to know what it is so that you know if it's dropped off, because hypotension is quite a late, but it's a very ominous sign. So you need to know what they were when they were wellish before you can decide if they're hypotensive and fallen off their perch. Doing a capillary refill. So you do it centrally, you hold down for 5 seconds, you let go, and you need to count again. The colour should return in about 2 seconds. 3 to 4, you're a little bit unwell. Anything over 4, you need to be worried. So the effects that cardiac inadequacy can have on other organs, they'll initially increase their respiratory rate, because this is to help them get that oxygen demand around the body. Their skin temperature and colour, so they'll start to get quite poor perfusion peripherally, because they'll shunt everything to their major organs and their heart so that you can perfuse your heart, your lungs, your brain. They'll eventually start getting quite agitated and drowsy if their cardiac output is really affected, because they'll stop perfusing so well to their brain. So you'll start to see agitation, and they'll be quite lethargic. And one of the other things that they'll do is they'll drop their urine output. So their kidneys will be one of the first things that'll stop working to help compensate. Kidneys and gastric. So they'll also stop digesting. Okay, so disability. So level of consciousness can be quite difficult to determine in kids, depending on their age and their developmental, whether they're developmentally normal, whether they're developmentally delayed. Parents, best key to understanding what their level of consciousness is like compared to their normal. Hypoglycemia is a lot more prevalent in kids. They've got a higher metabolic demand, especially in times of stress, so they chew through their glucose real quick. And they've got poor glycogen storage. They don't have as much to rely on. And smaller babies are dependent on glucose from feeding. So if they haven't fed properly in the last few hours, you need to be checking your glucose. They need glucose for their brain to function. So we say don't ever forget glucose. So you've got, primary survey A, B, C, D, don't ever forget glucose. So when you're doing a structured approach to disability assessment, you want to be checking their level of consciousness. So you can use your general GCS. You should also all have access to the modified GCS in terms of children. And then there's also an AVPU. I'm not sure if you guys have all heard of that, but we'll talk about that on the next slide. Their tone. So whether they're really floppy or whether they're sitting up, like the first baby in the picture, whether they're just lying there. Kids, even when they're sick, will tend to want to look around, to run around, to touch things. Hospitals can be a scary environment, can also be a really new environment, and there's lots of things to touch. If you put a 16-monther down on a bed and they look like that baby in the picture, you probably need to be concerned. Are they posturing? So are they doing like sort of decerebral or decorticate movements? What does their fontanelle feel like? So smaller babies will have that fontanelle on top of their head. Is it bulging or is it really sunken? They'll go sunk. It'll sink if they're dehydrated. It'll bulge if they've got like raised intracranial pressure. Or is it just normal? You just need to be checking that. So often I'll just do that when I'm having a chat to the parents. You can just rub the baby's head. It's quite easy to have a feel. Checking your glucose, and you also want to check your pupils as well. They should be equal and reactive. So AVPU is a really quick, easy way to do a GCS. So A stands for alert. Are they alert? Are they responding to voice? Are they responding to pain? Or are they unresponsive? And moving on to exposure. So thermoregulation in the newborn. So small babies have quite an immature hypothalamus. So they've got a really minimal ability to produce their own heat. They do have a little bit of small amount of brown adipose tissue, which produces a little bit of heat for them. But they're basically totally dependent on their caregivers to keep them warm and to keep them cool. You can also overdress a baby. They've got a large body surface area. So this means they've got a lot of surface area to lose heat from. So you need to be aware of that when you're examining them. They will lose heat through conduction, convection, evaporation, and radiation. So conduction, direct contact with a colder surface. So in terms of their examination, you need to be making sure that you're keeping them nice and warm on a nice warm surface. If you're taking them down to chest X-ray and they're lying on a cold slab in the X-ray department, you need to make sure it's a really short amount of time. And if they're faffing around and taking their time, pick them up, put a blanket over them, keep them nice and warm. And if you're in a resus kind of situation and you're having to have them stripped down, ideally they should be on like a resuscitaire with a heated mattress underneath, as well as the heat lamps coming from the top. I'm not sure if that's at all possible for everyone, but if you don't have that, you need to be making sure that you're keeping them nice and warm otherwise. They'll lose heat through convection, which is just heat loss due to the air movement. Evaporation, just due to the cooling effect of water loss on the skin, and radiation, heat loss from body to the atmosphere due to cool ambient temperatures. So you need to make sure it's nice and warm, and if it's not, they need to be snuggled up and dressed nicely. If they're hypothermic, it increases their metabolic demand, so it's going to be burning that oxygen and glucose even quicker. So a structured approach to exposure, you want to be checking their temperature. So don't keep them exposed for long periods. Also, you need to be aware that some babies and some small children will become hypothermic when they're unwell. They're not always going to be febrile. Obviously, if you have a baby that's just been born, you need to make sure you dry them and keep them nice and warm and do some skin to skin to try and maintain that temperature for them. For all kids, you need to be checking for rashes. Rashes come in a multitude of different presentations. Some of them can be really benign and most of them are quite benign, but some can be more serious. So it's really important that when you're assessing a child and you're doing your exposure, you actually need to mostly undress them. Whether there's any bruising or abrasions, obviously you need to be thinking about non-accidental injuries or neglect or anything like that. And then when you're exposing them, just remember thermoregulation for infants. And some older kids, even as young as sort of 4 or 5, they don't actually want to have their clothes off in front of everybody. So we need to be aware that we treat them like an adult. You're not just going to whip off their clothes and expect them to be happy about it. So in terms of other, they've got quite an immature GI system at birth. So their stomach capacity is about 10 to 20 mils in a neonate. So it's not much, it's a very, very small amount. And it increases to about 1,500 mils in an adolescent. So it's really common for them to spill post-feeds, whether they're breast or bottle fed. They just will drink more than they can actually hold. And bottles especially, people tend to overfeed them, so they spill, they're going to vomit. Quite important to know the difference between a spill and a vomit though, like obviously spills are just little ones where vomits can be quite big. They also take, they've got rapid intestinal peristalsis. So it takes about 2 to 3 hours in a newborn and 3 to 6 hours in infants or older children. Their lax lower esophageal sphincter is also associated with their spilling. They've got an immature immune function, so they're a lot more susceptible to infections, and they're quite reliant on maternal antibodies in their first week of life. So they do get some from birth, from being in utero. They also get some from breast milk if they're breastfed, but it's also really important that we vaccinate them and help protect them against preventable diseases. They've got quite a thin abdominal wall, which means they're a lot more susceptible to trauma because they don't have a lot of protection there. Their diaphragm and ribs are more horizontal and elastic. So it means that their liver and spleen are more anterior. So it's quite important when you are assessing an injury to the abdomen that they can be quite susceptible to spleen and liver injuries, where you wouldn't get that so much with an adult. Their ribs are more horizontal and elastic, which I sort of touched on earlier about why they increase their respiratory rate in terms of distress, but also that they can have pulmonary injuries without fracturing. And their bladder is also a lot more intra-abdominal. So when they're having like in car accidents or things, if they're not properly restrained and they've got like a normal adult seatbelt on, you can actually do damage from the lap belt to their bladder. And things like handlebar injuries and things like that, if they've got it sort of in that lower abdominal region, you need to be checking for bladder injuries.
A couple of common paediatric emergency algorithms. So there's the Paediatric Advanced Life Support and the Newborn Life Support. These are both available if you search Starship Clinical Guidelines, and then you just pop in Paediatric Advanced Life Support and Newborn Life Support. These are accessible to anybody all over the country. So you can look up any Starship Clinical Guideline and it's accessible to you guys. You don't need to memorize these. You can have them printed out in your resus rooms or where you might be assessing a child. We actually have them laminated up on our wall in our resus because we don't expect our staff to remember them either. Right, so moving on to common paediatric emergencies in terms of airway and breathing. So bronchiolitis is a big one, and I'm sure we've all seen a lot of it in the last few months. It's respiratory, it's caused usually by viruses such as parainfluenza or influenza. It's an acute viral infection. It's usually RSV, about 60 to 70% of them. 90% of infants are aged between 1 and 9 months. It's unusual to get over a year. We don't tend to call it bronchiolitis anymore once they're over 1. It's one of the most common serious respiratory illnesses of childhood and affects about 10% of our kids. It's most common in winter and early spring. So it's when the lining of the bronchioles are damaged, it results in bronchoconstriction and mucus plugging, which is why they get quite wheezy. They cough a lot, obviously, and sometimes when they mucus plug, they can get quite unwell with their respiratory. They get into respiratory distress quite easily. They'll also drop their sats sometimes, and often if you just pick them up, if they have a really big cough, they'll unplug that mucus plug and they'll come right a little bit. Day 2 to 3 are usually the worst. So if they're sort of presenting on day 1 and they're really sick, you need to be probably admitting them and monitoring them because they're going to get worse before they get better. If they're sort of day 3, you can probably monitor them and send them home, but it just sort of depends on what they look like. So it usually begins with urgy symptoms, followed by onset of respiratory distress, fever, and one more of the following. So they tend to have the cough, the tachypnea, retractions, widespread crackles and wheeze. Often it's audible. It's usually self-limiting, and it doesn't usually require any treatment or intervention. However, if it does, and if we do need to help them, it's just supportive measures. There is no cure as such. So we do things like positioning. If they're in a cot, we recommend that the parents put something underneath the mattress just to elevate it a little bit. You'll then need to get like a blanket and roll it into like a sausage and make like a horseshoe shape so they don't slide down the bed. And you can do that in hospital as well. Just make sure that something's under their cot so it's lifted, so they're sort of sitting upright instead of lying flat on their back. They're often better if they're upright on their parent. They can't sleep like that 24/7. Mum and dad need to rest as well, so it's really important that we make their beds as comfortable and as beneficial as possible. Saline drops usually work really well in bronchs, especially before a feed. It just helps break up all that snot. Because they're nasal breathers, it means they can breathe and feed at the same time. Suctioning. So we can obviously suction. We would use a small, like 6 or 8 French suction catheter and pop it down, back and over as if you're inserting an NG, and then give a good suction on the way out. Parents don't have that at home, so they're not going to be able to do that. They've got a couple of options. You can get little sucky, bulby things from the chemist. I don't know how good they are. The other thing that they can do, and most people get gross by this, but you can tell parents that they can put their mouth over baby's nose and suck it out with their mouth. It's a bit gross. It is effective. It does work. It's your own kid's snot, so it doesn't really matter. I have done it. I've done it myself. Otherwise, they can't breathe. If they can't breathe, they're not going to feed. We only give oxygen to keep their sats above 92%. Anything 92 and above, they're fine to truck along. We've got some different options in Starship, and obviously you're going to be limited depending where you are in the country. So we've got normal nasal prong oxygen, but just from the wall oxygen up to sort of 2 litres. We've also got heated humidified high flow nasal cannulas, which are really good in terms of getting humidified oxygen. You can do a lot higher pressure and it's a lot more comfortable for them. CPAP, if they're needing CPAP, they're in our ICU, and then obviously the next step is going to be intubation. Those are obviously your very, very unwell bronchs. They're quite at high risk of dehydration because they're not going to feed because they can't breathe through their nose. They also, because they're working so hard to breathe, their tummy needs to be small so their lungs can expand properly. Their body needs to concentrate on the breathing, so it's also not going to digest any feeds. They tend to vomit a lot, or they're just not interested in feeding. So what we advise parents do is give short, frequent feeds. So instead of like sort of 4-hourly feeds of either a really good breastfeed, so either both sides or a bottle, half that and give it more frequently. So 2-hourly feeds of half what they're used to. If they're not tolerating that or they're not interested, we will move to a nasogastric, and they're either going to get bolus feeds, and if they're not tolerating that, then we're going to give them a continuous feed. If they're not tolerating that, then they're going to need IV fluids. They need something to keep them hydrated. There's not been not a lot of evidence in terms of bronchiolitis over the years. Nothing really changes the course of its illness. Supportive management remains mainstay, so just oxygenation and hydration. So there's no efficacy for salbutamol, chest x-ray, antibiotics, steroids, or adrenaline. So there's no evidence to say that any of those things are very beneficial. Sometimes salbutamol on the older babies, kind of 9 months plus, we will often give it a try if there's a really strong family history. So if the kid's covered in eczema, mum and dad have really bad asthma, there's an older child that's a really good going wheezer, sometimes we'll have a go and see if it's effective. Obviously, we don't recommend people try that at home. It needs to be monitored in a healthcare environment. And then sometimes that will help, and then we can treat them with that. But often it makes absolutely no difference. Chest x-ray is probably only going to show you hyperinflation. It doesn't really tell you a lot. Antibiotics aren't going to help because it's a virus. Steroids used to be kind of common practice. It's not really anymore. There's just no evidence to support it. And same with adrenaline. And that's the Australasian bronchiolitis guideline, which you can Google if you want to have a read. These are like, which you can't access because it's the thing, but anyway. So asthma is another one that we see a lot of. Obviously, these older kiddies. Tends to be, there's a lot of debate about when you diagnose asthma. My understanding is it's about from 5. So if you've had multiple episodes of viral-induced wheeze that is salbutamol responsive, then we can label them an asthma. It's very common presentation. Again, there's not a lot of significant changes in the acute management. Inhaled corticosteroids make a positive impact, and they need a metered dose inhaler and spacer for acute episodes and inhaled steroids. We use spacers. We tend to do 6 puffs, and we do 6 breaths per puff is what we teach our parents. So they do 1 puff, the child has 6 breaths, give it a shake, and do that times 6. Everyone needs to use a spacer. Even adults should be using spacers. Puffers just don't get inhaled properly when you're not using one. So every child you see should be using a spacer. If they're small, they need a mask. If they're bigger, they can use the mouthpiece. You need to be checking that parents can deliver this effectively before they go home. Some kids hate it. There are different positions you can teach parents. If they're doing it by themselves, one of the best ways is to sit on the floor with your legs out flat, have the child in between your legs, wrap your legs over their body, and have their head sort of in your lap, and then you can hold their head and give them the spacer. Seems a little bit cruel and unusual, but it works. There's not a lot of evidence to say that nebulizers are more effective unless there's an oxygen requirement. So unless our kids have low stats, sort of under 93, 92, we tend to go for spacers over nebulizers. For severe asthmas, your treatment, start with your doctor's ABC. going to give high flow of about 15 litres per minute. We can give salbutamol nebs, again, if they're hypoxic. You want to give 5 milligram nebs, and we can give them continuous. Sometimes, quite often, we add some atrovent, some ipratropium bromide of about 0.25 mg per neb. We tend to do 3 in a row, so you do 3 salbutamol with atrovent in a row, and then you just sort of switch to salbutamol, which you can give as often as you need, and then atrovent will be 4 hourly. In terms of our life-threatening asthma protocol, we will get some IV access in, and we'll start to give steroids. So our first line of treatment after nebulized salbutamol will be steroids, so IV hydrocort, 4 mg per kg. You can give PO prednisolone of 1 mg per kg. If they're really severe and they're working really hard, they're going to have reduced gut motility and they're going to vomit. So you're better off going for the IV route, because you know it's going to be absorbed and you know it's going to work. If you give them pred, they're more likely to vomit it up, and then you've kind of lost it. They can have IV salbutamol. This is when they're quite severe. If available, we give IV mag-sulf of 0.2 millimoles per kilo to a maximum of 10 millimoles, and also aminophylline 5 to 10 mg per kg. That's kind of our life-threatening asthma protocol. This is all available. Again, it should be on the SARTIC clinical guidelines under asthma if you wanted to look it up. You can give IM adrenaline as you would for anaphylaxis. This is kind of sort of a peri-arrest, and often sometimes with asthmas you can get a little bit confused between asthma and anaphylaxis. So sometimes a bit of adrenaline might help you sort of solve that problem. And you, obviously, if you need to transfer them out, you're going to need an ambulance. So in terms of common paediatric emergencies for circulation, sepsis, it's relatively rare, but it is associated with a really high incidence of morbidity and mortality. So about 10% will actually pass away from sepsis. It can be caused by any organism. It can be bacterial or viral. It needs to be recognised and treated early. And I think worldwide, we're very bad at that. It's really hard to detect sepsis, especially in kids. High-risk kids to keep in mind are any child under 3 months of age. They're really high risk for sepsis. If they're already immunosuppressed, if they've got indwelling lines and catheters, so the kids with the peripheral, your PICs, your ports, your Hickmans, all those kind of things. If they've got like IDCs, anything like that. And children presenting with petechial or purpuric rashes. So the rashes can be quite a late sign, but it's not always. So you need to be treating every petechial or purpuric rash quite seriously and monitoring it. So in terms of sepsis, you have systemic inflammatory response syndrome. So the infection has starting to have a systemic involvement. It's why it's sometimes really difficult to recognise early, especially in the triage setting, because if you think of any two of the top, so your temperature of above 38.5 or under 36, tachycardia or bradycardia in the absence of any other cause, tachypnea or elevated or depressed white cell count, they're all common presentations of most viral illness that kids present with. So it's that's what's really important to look at the whole picture and decide whether or not the numbers that you're getting or what you're seeing fits with your differential diagnosis, and always think, could it be sepsis? Yeah. So it's a key indicator in the diagnosis of sepsis, but its symptoms mimic other paediatric presentations like viral illness. So it's kind of why we sort of talk about how it's so hard to recognise. So sepsis, early to severe. So SIRS, which is the systemic inflammatory response syndrome, in the setting of suspected or proven infection. So you know they've got an infection, or you're pretty sure they've got an infection, and you've got two of the others. Then they move onto septic shock. So they're starting to show signs of cardiovascular organ dysfunction.
And hypotension, again, is quite a late sign. So you need to be doing regular blood pressures on these kids. It's really important to monitor your systolic blood pressure, but also your pulse pressure. So they tend to widen. So your systolic will truck along for a while, and then your diastolic will start to drop, and then your systolic will follow. So it's really good to be able to look at a pattern. And severe sepsis or septic shock should be suspected in any child with signs of sepsis and who have an altered mental state, poor peripheral perfusion, and a narrow pulse pressure, which can indicate cold shock. So cold shock is also a weak and thready pulse. They've got cold hands and feet. It's quite common in the younger paediatric population. But warm shock is also possible, just to make things a little more complicated. This is when they're quite flushed, they've got bounding pulses, and they've got the widening pulse pressure. So they kind of got, they're not cold, they don't look mottled and unwell, but they still look really sick. If they're tachycardic with no other obvious cause, so we kind of advocate that you don't need to give paracetamol for fevers. Fevers are a good thing. It's what the body's designed to do, blah, 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 blah. But 99% of our clinicians in our department will want to give an antipyretic for a fever, purely so we can make sure that that tachycardia settles with that fever. If they remain tachycardic and they're afebrile, we need to be more concerned. Tachypnea with or without hypoxia, so they can be working really hard to breathe and they might not become hypoxic, they might, and they just look really unwell. Again, all these are very ambiguous, so it kind of just goes hand in hand and sort of highlights how it is really hard to sort of tell sepsis. And again, in terms of sepsis in the neonate, just to really throw some stuff out there, it's non-specific. It's really progressive. They've got no immune system. They've got nothing to fall back on. Infection can take over like no tomorrow. It can look like anything. They can come in irritable. They can come in sleepy. They can come in with decreased feeds. You name it, they will come in with it. And it could be something and it could be nothing. They may present, well, there you go, present with reduced feed, present with vomiting, present with reduced tone. They might be febrile, they might be hypothermic, they could also be normothermic. They might present with apneas, and they could present with lethargy or reduced level of consciousness. Neonates are really, really difficult. They're basically sick until proven otherwise. Parents of neonates, especially if it's their first baby, struggle to comprehend what's normal and what's not for a neonate. So they'll bring them in for something that might be nothing, but we need to prove that it's nothing. We need to look at everything before we can say, yes, that baby's fine. Because if you get it wrong, it can be catastrophic. In terms of treatment, so for A and B, you're going to put high flow oxygen on a septic patient. You might need to provide a little bit of PEEP. You're probably going to intubate. This can be quite risky in severe sepsis and septic shock. You're going to want to choose ketamine as your induction agent of choice. Propofol will drop their blood pressure, which if they're already teetering on the edge or they're already becoming hypotensive, you're just going to drop them out. You're going to lose their cardiac output pretty quick. Fentanyl can be another suitable alternative. So obviously avoid those that cause hypotension like propofol. If you are going to intubate, it's probably a good idea to have some addressed doses of adrenaline drawn up and ready to go. You want it to be quite controlled. You want everyone to be on the same page and everyone be ready for it just turn south. Make sure you get rapid access. So if you can't get an IV, you need to go straight to an IO. Don't muck around, just get access. You need to take bloods. You want to be getting a full blood count, a peripheral blood culture, your blood glucose, urea, electrolytes, creatinine, liver function tests, venous blood gas to check their lactate. And you also be looking at the coagulation profile. You need to, for fluid resus, if possible, you want to warm it. It needs to be rapid.
you want to be giving 20 ml per kilo boluses of normal saline up to about 40 to 60 mils per kilo. That's in total. So once you've sort of done 2 or 3 boluses, you need to sort of be deciding whether you're going to switch to something else. Large volumes, sort of over 60 mils, can lead to hypercholelemia and increasing acidosis. So it can sometimes be counterproductive. So you need to be careful, which is why it's also really important to sort of be repeating your bloods. Repeat your assessment in between. So when you're giving 20 ml per kilo boluses, check, see if you're making an effect before they decide to give the next one. And if you've sort of given sort of 2 to 3 boluses, consider albumin 4% if you're needing to fluid resuscitate further. And if they're showing signs of coagulopathy, give some fresh frozen plasma. Evidence suggests that rapid fluid resuscitation may have a key role in preventing end organ damage and improving survival in a developed world setting with intensive care support. So fluid resuscitation is really important in sepsis. We need to be getting onto it early. Once you've sort of sorted that, you want to be looking at some inotrope management. I'm not sure if this is kind of outside of your scope in terms of where you're based, but you want to be looking at adrenaline, dopamine, noradrenaline. There's a link to the Starship Emergency Drug Calculator. I'm not sure whether you guys use this or have your own version, but it's a really good link, and it gives you the commonly used infusions in terms of a resus, as well as your emergency drugs. So D, if they're hypoglycemic, treat that with a 10% glucose, 2 ml per kilo rapid push. Just push it in. You can push it into an IO or an IV. You want to treat with antibiotics. IV Kefatax, 100 mg per kg is our loading dose. If they're under 6 weeks, we're going to add amoxicillin 50 mg per kg as well. Additional antibiotic coverage might be required, so you might need vancomycin for pneumococcal or MRSA. Acyclovir if you've got a possible herpes simplex involvement. And then there's the febrile neutropenic antibiotics are slightly different again. So again, they're available on the Starship clinical guidelines under febrile neutropenia. And if you need to prepare for transport, you're going to wanting to get these kids probably out of your departments pretty quick. We do. We send them down the corridor. So in terms of common paediatric emergencies for disabilities, they're very high risk for head injuries. They've got a very large and heavy head. They've got a natural explorative nature, and they lack any sense of danger awareness. So they'll walk forwards down steps when they are not physically able to. They'll walk off things because they don't know how high it is. They'll walk out onto the road because they don't understand that a car's going to come and take them out. As they get older, they are they like to take risks. So adolescents think they're immortal. They will do things that aren't compatible with life without realising that it's not compatible with life. In terms of head injuries, treatment for a moderate to severe head injury, you're going to oxygenate. We want to tilt the head of the bed to 30 degrees to help gravity to drain that fluid away from their head. Just keep in mind their C-spine, if it hasn't been cleared, you need to keep them immobilized, whether it's with sandbags. We don't use hard collars anymore. We just tend to have sandbags on either side of their head, and whoever, someone's in charge of making sure they don't move. Smaller kids, you need to weigh up whether having them lying still on a bed is going to be doable. If they are writhing around and thrashing, they're more at risk of damaging the C-spine than if they're nice and calm seated on mum. So get mum or dad to sit on the bed and have them cuddling them and helping them keep their C-spine immobilized. Capnography to reduce load on the brain. You want to be maintaining their blood pressure. So we will give 3% saline, and I can't remember the dose. I'd have to look it up.
The other option is mannitol, which is over 20 minutes, whereas, here we go, sorry, hypertonic saline, 3 to 5 mils per kilo. And that's a rapid, and that's just a rapid push. But be aware it may drop their blood pressure, so you need to be doing sort of 5-minute lead blood pressures. And then hopefully they're going to get to CT if you've got one available, and preferably theatre. But again, it depends on what's available in your area. You might just need to get them out. Seizures, very common in children, it can be. Causes include fever. So a febrile convulsion, it's not how high the fever goes, it's how quickly it gets there. So a kid can sit at 40 degrees, no dramas. If it's gone from 36 to 40 in a half an hour period, they're more at risk of that febrile convulsion. Just because they've had one doesn't mean they're going to have more, and it also doesn't predispose them to epilepsy. Really awful to watch. Parents hate it. It's awful to watch as a health professional. It must be terrifying for a parent. Sometimes they can have more than one in an illness, but it is uncommon. Obviously, epilepsy, meningitis or encephalitis can also cause seizures, hypoxia, metabolic abnormalities, usually because they have a metabolic condition. Toxins are a big one. Again, it's really important to get that history. If they're hypertensive, and if they've got raised intracranial pressure, so they might have a bleed, or they might already have like a ventricular peritoneal shunt. If that gets blocked, and ICP is going to raise and they can have a seizure. If it hasn't self-resolved within 5 minutes, we will need to treat it. The longer the seizure goes for, the harder it is to terminate. So once you're kind of going over 15 minutes, it's harder to stop it, even with medication. A seizure over 30 minutes or a recurring seizure where the child doesn't regain consciousness in between is classed as status epilepticus. And again, there's a link for the Starship Clinical Guidelines for status epilepticus. Just Google Starship Clinical Guidelines, pop in status epilepticus. It all comes up. That's the algorithm. But again, that's available for you guys to have a look if you want to. Okay, so paediatric essentials. So things to remember when you're dealing with kids. Family-centered approach. It's really important to involve your family. Not only do they know the child the best, but they also feel empowered when they're being involved. So they need to be able to make decisions. Give them informed information so they can make an informed decision. But use them. They're your best tool. They know the kid the best. They're going to calm the kid. They're going to help you. I know people don't like peds, but they're great because you just walk away and leave them with the parent. That's what they're there for. I don't take people to the toilet because that's what a parent is for. Educate and explain as we go. So discharge planning begins at admission. So everything we're doing, we're educating the parent for. Even those kids that have on their 3rd or 4th episode of viral induced wheeze, you will still find that parent will be administering the spacer incorrectly. So we need to be educating and explaining everything as we go. They know their child the best, so acknowledge them and utilize their knowledge. Especially important in chronic kids, so those with cerebral palsy or muscular dystrophy, anything like that. They know what's normal for their kid. They know their child's condition inside and out. They know them way better than what we do. Use them, ask them questions. They're more than happy to tell you. If your parent doesn't trust you, their child won't trust you. So build your rapport. Often with kids, you kind of ignore them to begin with and just talk to the parent. And then once the child sees that mum or dad are happy to talk to this person, they'll kind of open up and then they'll be fine as well. So children love to learn and interact by play. So we use a play-centered approach. Bubbles. I don't know if you guys use bubbles, but they are cheap and effective. Kids go nuts for bubbles. A child that is flat out refusing a SATS probe on their finger or their toe will suddenly cooperate once you blow bubbles. Incorporate play into your care. So don't be scared of them. I mean, some people aren't kid people, that's fine. But if you talk to them on their level and you get down and you want to play with them and maybe you have a colour or maybe you show them a toy, they're more likely to cooperate with you and therefore you're going to make your job so much easier.
Use distraction. So kids are, I won't say stupid, but they're easily distracted. Little ones, you can blow bubbles or show them a book and show them something on the phone and they're too busy looking at that, they don't care what you're doing. Prepare your child for procedures using play. So some of the older kids, you can show them on the teddy first, like Teddy needs to have his oxygen levels checked, so we'll put the probe on Teddy first, whatever. Use things to help you. Use appropriate language that they can understand and that they can relate to. We need to be careful about our choice of terminology. Things like needles and jabs and injections and pricks, things like that, they're scary words and kids aren't going to respond appropriately to it. So if you're wanting to do an IV line, just say it's going to be a sharp scratch. On the other hand, some kids thrive on, they want to know everything. So have a chat to the parent in advance and decide whether or not you're going to show them everything and explain everything, or whether you distract them and kind of do it on the sly. But don't lie to them. Never lie to them. Don't tell them it's not going to hurt. No, it's going to hurt. You'll lose their trust and it's over. So if it's going to hurt, say, yeah, it will hurt a little bit, but it's going to be really quick and mum's going to be right here and she's going to give you a cuddle, and afterwards you're going to get a certificate or a book or a sticker, or they love things like that. Again, talk to your parent. Ask them the best way that they think the child's going to deal with it. So sing to them, use rhymes, play a song on your phone, just use what you can. In terms of preparing for procedures, give older kids choices, but it's not actually negotiable. So yes, they can pick which hand they have their IV line in, but not having it is not a choice. So give them options where you can, but make sure they know that actually it's going to happen and it's going to happen anyway. Again, be honest, offer rewards. We have procedure rooms where we do all our painful procedures. So we take them away from their rooms into a room which is all brightly coloured and beautiful and fantastic. That's where we jab them. Then we take them back to their room. That's their safe zone. So they know that in that room nothing bad's going to happen. If you have to take them back to the procedure room, it's a little bit more difficult. Make sure you're ready to go. So try and have everything set up and ready, because the more you faff about and start like trying to set everything up, the more anxious they get and the harder it's going to be. Parents should be there all the time unless they don't want to be. Sometimes with NGs, parents prefer to be out of the room, and often that's okay because it's usually little babies and they don't really know, but otherwise get them to be there, help them, educate them, explain to them, get them to help you explain to the kid. Make sure you're allowing time. So we use Amitop for topical anaesthetic in terms of IVs. So sort of preempt that if you can. If you know that the kid's going to need an IV line, make sure you're putting it on in sort of half an hour, or if you're using MLF, 45 minutes in advance. So by the time they need the IV line, it's cooked, it's done, you're ready to go. And often make sure you do give them that warning of 1, 2, 3, scratch, and your holder needs to be holding real tight. Procedural positioning, so wrapping, great for those kind of toddler ages. You can just wrap them real tight, they can't move. Use the caregiver, hold them chest to chest, or side sitting position, so they're sitting on mum or dad with their legs out, and then mum or dad can hug them to the side. On a bed, use a large book or a page to distract and obscure their view. We've got big A3 laminated like I Spy and Where's Wally's. So not only is the kid distracted, but you can use it as a shield, so they actually can't see what's going on. Oral sucrose is great for kids under 3 months. It's a great pain relief. And breastfeeding. So if your child is breastfed, doesn't matter what age, if that's what they're comfortable doing, not only does it provide a little bit of analgesic, but it's optimal position for them. If you can, as long as you can get to whatever you need to do, they feel safe, they're comforted, it's perfect. So sucrose is, that's the dosage. Works really well with a pacifier. Even if the kid doesn't take a dummy normally, they'll often suck on it if it's got sugar on the end of it. So it works quite well. You want to give it about 2 minutes prior to what you're about to do. And it doesn't matter how, there's no minimum time between doses, but you're giving a sort of a maximum of 4 doses, and it lasts about 5 to 8 minutes. That's just a picture of a good position. The Superman, I don't know what that says, something, I can't say, something. It's really great if your parent is on board with it. So you just get a pillowcase and lie them on the bed. They're lying on the pillowcase and they can't move their arms. So their arms are like down. It's kind of a wrap, but for the older child. So they think it's real fun to begin with. And then once you lie them on the bed, you can do what you need to do. And then they're nice and secure, and then you can let them up. Obviously an IV line's not going to work like that, but if you're needing to do an NG or a suction or something like that. And then that's the next bit, but that's going to take a while. So shall we wrap up there?
Fantastic. Well done, Natalie. You covered so much in such a short time. I'm trying to catch up. Well done. So far we've got one question come in. You've covered it so well. I think everyone's questions and maybe answers, they might start coming in now though. So we've got Carly Smith, currently having her potluck dinner with 6 other people.
Very nice.
And she's asked, are cold shock children or warm shock children more unwell?
It's more, they're about equal. It's more their age. So cold shock tends to be your smaller children, so kind of like your babies and toddlers, and warm shock is kind of the older. So both are severe. They're both indicating that you're septic and you're in shock. But it's more indicative of the age range as opposed to one's worse than the other.
Can you please tell me again what age you would start calling a child asthmatic?
So my understanding is it's over 5, but they also have to have had multiple presentations of viral induced wheeze before we label them as asthma. But that tends to also be, everyone kind of has a different opinion. So I'm not sure if there's an actual like specific guideline. My understanding is everyone kind of has a different view on it, but that's kind of what we go for in Children's ED Starship, is it once they're over 5.
And then we've got sponge or just light clothing for a febrile child.
Just light clothing, so strip them down as much as possible depending on the environment. Obviously if it's really cold, you don't want to be stripping them down to their nappy or their undies. But you don't really want to be sponging them down like a wet cold cloth all over their body, because you actually make them start to shiver and their body gets really confused and it's not good for them. So just strip them down is the best way, and lots to drink. If they'll drink is another way to help bring it down naturally.
And then we
are very against like cool baths and things. Like, we don't recommend that at all for parents.
And then we've got, could you please explain the use of sucrose pre-procedure?
So it basically just acts as a really good analgesic for small babies. It's not so effective over 3 months. We use a special, can't think of the word, I want to say concoction, but made up bottle from pharmacy. So I'm not sure if that's available in your areas, but it's ultimately just kind of sugar and water. And it's weirdly makes a great analgesic. They just suck on the sugar and they don't even cry with an IV line. It's very bizarre. I'm not sure of the pathophys behind that, like all the pharmacokinetics, but it works.
Thank you. And then we've got, does Starship Guidelines have an app for guidelines easy to access on your phone like the Royal Melbourne Children's app, or just Google?
I think at this stage it's just Google. We've got a script for antibiotic treatment, which looks like that. So it's just called Script, and that's free. And I think that's kind of ADHB because it's adults and children, and that's great. It's like a step-by-step. So when you go into it, it comes up with the different systems. You click on it, it asks you some questions and you answer them, and then it gives you the ideal antibiotic and dose range. But in terms of guidelines, no, I don't think we do, sorry.
And then we've got, how persistent are you with oral rehydration before looking at NG?
It depends on their age. If they're just refusing it, if you can sort of fix the problem of, do they have a sore throat or are they febrile, and if you're giving sort of pain relief or antipyretics and that settles down, quite often they'll drink. If not, it really depends on their level of hydration and their age. If the younger they are, the more risk they are of it dehydrating quicker. So we need to be just assessing their hydration status as we go and sort of make a decision. I personally am on the more persevere a little bit longer with oral hydration, because NGs are quite cruel, but sometimes it's a necessary evil. So.
And then we've got, is there any tips or tricks to help count pulse? Find it hard, as don't do it often.
So if you're not using a monitor, sort of stethoscope's probably the easiest way, especially if you can do it on their back. Smaller kids, brachial is the easiest way to feel it. Older kids, I was doing manual radial, but we tend to use monitors, which isn't the best. We're quite monitor reliant in our department, but we've also got the little SATS probe that wraps around their fingers, so it's a little bit, we don't just have the crocodile clips, which are a bit tricky. So probably stethoscope, if they're younger, would be my go-to.
And someone just asked if you could just remind them what PEEP stands for, please.
Positive end expiratory pressure. So it's that amount of pressure you have at the end of your expiratory, which is always there.
Thank you. And I think other than that, it's people just saying fantastic presentation. Thank you. Obviously, it's been a great refresher. But yeah, generally just lots of positive comments about how much they've enjoyed your presentation. Thank you, Natalie.
Oh, good. Well, I'm glad I could assist.